The first talk we're going to do is pediatric rehydration and feeding. And the reason I think that this is a good topic is that it appears to be evidence proof. I don't know about you, but you hear the people giving advice to mothers about what they ought to do with Johnny or Mary who's got diarrhea or vomiting kind of thing. And you just hear everything known to man, and then the nurses have their version of it, and yet the fact is it's really pretty straightforward. I believe that it was fairly complicated, but honestly, it is fairly simple. It is fairly simple. To start out with there, I think that we're going to need two numbers. We're going to need to know what is the maintenance fluid for a kid and what is the replacement for a kid. And as soon as we start saying that, it's like, geez, this is complicated, forget it kind of thing, I have to look it up. But honestly, it really isn't. A 10-kilogram kid is 22 pounds, is a 1-year-old. And a 1-year-old requires 100 mLs per kilogram just for maintenance. So a 1-year-old basically requires 1 liter. 1 liter for a 1-year-old kid. Now, you put that in perspective. If you have an adult, and say for the sake of discussion, the adult is 100 kilos, that adult would have to drink 10 liters of water or liquid a day proportionally to a kid who's a 1-year-old. So that makes it clear that these kids disproportionately require a lot more fluids than we would think is reasonable for them. So the first 10 kilograms is 100. The second 10 kilograms of their weight is 50. And the third 10 kilograms and above is 20. So that basically tells you how much they need within 24 hours to just kind of be even. And then the other numbers we need to know is mild, moderate, and severe dehydration. We don't want to talk about percentages. That's too hard. You decide, is this kid mild, is this moderate, or is it severe? You make a decision based on all of the data that you get from the parents, the lab, the examination of the kid. And a mild dehydration needs 50 mLs per kilo, moderate is 100, and severe is 150. And I don't think that's in your book. So if you want to write that in the margin, 50, 100, and 150, that's all you need to know in terms of how much. And then the question will be what and how quickly. And that's really pretty straightforward too. So 100 for the first 10, 50 for the second 10, 20 for every kilo thereafter. And mild, 50 mLs per kilo, moderate, 100, severe, 150 mLs per kilo. All right. What is the baseline weight in a kid in terms of how do you know how much they're dehydrated? All of these studies kind of look at the gold standard is what they weighed when they were well. But you don't know what they weighed when they're well. So in these studies, after a couple of weeks and their kids are back to normal, they weigh them and say, okay, this is the well weight. Now this was the dehydrated weight. This now allows us to determine what percentage of the kids in our study had severe dehydration, mild or moderate. So the well weight. The first paper here says you have to take the diaper off to weigh a kid. And surprisingly, the answer is no. You would think that diaper would weigh 2-3 pounds, depending on what the heck's in that diaper. But this says, no, that you don't. And as a matter of fact, this is a large study, 217 kids, and they weighed them with the diaper and without the diaper and looked at the difference in the weight. The difference was small, at 1.2%. 1.2% is of no consequence, no consequence. There was only 4 kids whose weight was more than 3% difference, dry weight versus the diaper weight. And 3 of those are neonates, defined as a neonate's the first 28 days of life. So if you have a neonate, maybe you want to take the diaper off. But to tell you the truth, we don't care that much, Everybody gets weighed, but I'm not sure why. I mean, we're not going to be giving these people weight-based doses of much of anything. But it's the ritual, you got to do it. So just leave the diaper on, and you don't have to be a purist about it. There's a summary of 13 studies, which is the second paper, and it makes a number of conclusions. First of all, it says parental reporting of symptoms it doesn't turn out to be particularly useful. I mean, all these parents come in and say, he hasn't peed for 2 weeks. You know that can't be possibly true. And that's a recurring theme, but I'll show you a paper that says maybe if we ask them better, we'll get better information and make it more consistent with whether these kids are dehydrated or not, whether it be for vomiting or diarrhea. They also talk about all of these classic findings: sunken eyes, dry mucosas, cool extremities, weak pulse, absence of tears, heart rates elevated, sunken fontanelles. Well, all of those are kind of bad. They reflect on somebody who's really pretty nasty. But one of the things that paper says is How good are those in terms of picking out whether in fact dehydration is going to be there? They talk about low likelihood ratios. So the likelihood of you having sunken eyes in a kid who's dehydrated is very, very low. The likelihood of you having, doughy skin is very, very low. And then you get into inter-rater reliability. You get 3 or 4 doctors, and you all ask those doctors, what do you think about this kid? And they all will make different judgments. So that's one of the other issues. And then they also talk about wide confidence intervals. And we probably ought to talk about this concept because you'll see it in the book a lot. CI, confidence interval. And say for the sake of discussions, conceptually, we have a person who, we have a study, and in the study we determined that 70% of the doctors are really good at determining how dehydrated these kids are. 70%. That was the result of the study. And the confidence interval in that study ranges from 70% to 80%. The doctors got 75%. Let's say that. Confidence interval 70 to 80, 70 to 80%. That means that if we do this study over and over and over and over again, we're quite sure within a 95% likelihood that the results will keep on coming out somewhere between 70 and 80, 70 and 80. Now on this study we got the answer was 75, but the next time we do the same study we might get 72, and the next time we might get 78. So it tells us that that is the range where we can expect the results of this study to be all the time. So we can feel confident in extrapolating this. This is the neighborhood we're talking about. Now what if they had a confidence interval that said, the confidence interval, well, the doctors got 75, that was the results of the study, but the confidence interval was plus or minus 20. So the confidence interval went from 55 to 95. That means every time we do this study, we're going to get an answer, but that answer is going to be somewhere between 55 and 95. So that's called wide confidence interval. That's not good. We want narrow confidence intervals, because if you got 75, you could still be way, way off in the reality, in terms of what is the reality, in terms of the real answer, when the confidence intervals are wide. So look in your books. You're always looking for narrow confidence intervals, and the way you get narrow confidence intervals is have studies have lots and lots and lots of patients in them. So that means that you can, now sometimes the confidence intervals are so narrow that you get into an issue of, well, that's the answer, but is that clinically a relevant answer or not? We'll talk about that a little bit too. They also talk in this paper number 2 about what blood tests. And basically the blood tests are surprisingly, they said BUN has to be real elevated. Bicarbonate. Bicarbonate comes up a number of times, and bicarbonate really is about starvation. And one of the things that appears to be underappreciated in these kids is the amount that they are calorie deprived. And so if you have somebody who now is calorie deprived and they basically are breaking down their fat, they're becoming ketotic, and basically that's going to be reflected in their bicarb. So it's really a reflection of nutrition in addition to maybe a little bit in terms of volume. A normal bicarb, it would be highly unlikely that this kid is significantly dehydrated. And like all kinds of issues, when you make a diagnosis, the more elements that you have in that diagnosis that are consistent with the diagnosis, the more likely you are to have it. So obviously we don't hang our hat on 1 or 2 kind of findings. I think that this, and it also mentions about the World Health Organization, and they're another group that says, hey, don't worry about 5%, 10%, just say, make a judgment. They say none, some, or severe dehydration, none, some, or severe. I do like the none, mild, moderate, or severe personally, because we have the numbers now that we can use to try to fill up the tank, mild, moderate, severe kind of thing. If we make a decision based on our clinical gestalt about what this person's about. You know, some people use this thing of capillary refill. Capillary refill is got a bad, here's number 3 talks about 3 studies. Inter-observer agreement was found to be only moderate on capillary refill. You got to be pretty down the road before your capillary refill is screwed up. But the paper I like to boast about it is a new paper. It's number 4. So they got a machine now that presses your finger down, and they have a camera that takes these rapid pictures and very accurately measures capillary refill. And when you use their machine and camera setup, their machine and camera setup has picked up every kid in this study who was severely dehydrated. 16% of them, everyone, 100% sensitive, picked them all up. But I like the conclusion at the bottom. It said, what about doctors' ability to pick up capillary refill problems, and how did it link up with the fact that 16% of these kids were severely dehydrated? Capillary refill assessment only picked up half the cases. So it basically reflects that a lot of variability in terms of our ability to pick it up. Overall clinical assessment picked up only 3/4 of the kids who turned out to be severely dehydrated. That's probably good enough though. How valuable is the parental history? Number 5 says, give them a computer, ask them a whole bunch of questions, and you'll get a more reliable answer. No one will bother with that. The value of lab testing. I don't know about you, but in my experience, you're either a tester or you're not. And some people love tests, and some people really don't. And in kids who have, vomiting and dehydration, there are the doctors who are the testers and those who are not. And these papers, by and large, say you're not going to learn very much. But I do think there is 2 things that come out of these papers that are a recurring thing that should, I think, change your practice. The first paper here involves a pediatric academic center. Well, that means that there's 4 standard deviations of the bell in terms of where they are. And the question is their practice exemplary practice? Is their practice something that should be emulated, or is this the practice that evolves from a person being in a training institution where they're training to over-utilize tests? In this paper, they basically there was, on the average, 59% got tests at baseline for gastroenteritis. So I'll put that in perspective. Do 60% of your kids get some kind of blood tests? I don't think so. Well, we have a doctor, it's probably 70%. He never met a test that he didn't like. But most of these kids, it's just a matter of recognize the problem, fill up the tank, give them, refeed them, and you're done. So the question is really, what are you going to get out of this? Well, in any case, they put on a computer ordering screen. A lot of you have the CPOE. Physicians are now ordering the stuff on the computer themselves. They got rid of all the clerks that were supporting you, and now you are the data entry person, and you're not supposed to make more errors by that. You're supposed to be wonderful, basically a lot of crap. But they put the prices of the tests on there, and the doctors went from 59% of the patients getting tests down to 34%. And every study that does that, where they put the price on the screen, it goes down. The question is how sustainable is that? Does it stay down for a month, or 2 months, or 3 months? Because basically you're going to think that it's going to go kind of back up to normal when they get immune to these prices in terms of making their decisions. Number 7, 182 all had lab tests. 180, every one of those buggers had lab tests. And here's a couple paradoxes in this paper. Despite the perceived need for IV rehydration, 60% were considered to be mild. American Academy of Pediatrics, World Health Organization, and the CDC all say mild to moderate dehydration is oral rehydration therapy. And yet in the States, our threshold for plugging in IVs is very, very low. And so we have kids who have mild dehydration getting IV started. And when you look at these papers on IV start, they're all getting stuck 3, 4, 5 times in the process. Now we have a little bone drill, put that thing in there, kind of screw it in, feed them through the femur kind of thing. So that was a bit of a paradox. They're giving IV fluids to these kids who have got mild dehydration, and only a small subset of them had only a small subset had severe dehydration. Well, in this study, 10% of all the kids had abnormalities in their lab tests and said, oh, this is good. High yield, let's do lab tests on every kid because we got 10%. But that was, half of them had abnormalities, but only 10% were considered significant. What were those abnormalities? And that's the point here. It was low sugars and low bicarbs. Low sugars and low bicarbs. And I think there's a couple papers here. Low sugars are unpredictable who the kids are that have it. There's no manifestations. So they say, and there's one paper here, number 8, the lowest glucose was 34. And 196 kids, 18 of them had glucoses below 60. Most of them were between 50 and 60, which would not be considered terrible, but you don't know who they are, and there's a kid with a 34. So the lab test that you should get is probably stick the kid's finger and see whether this kid is starving, is manifested by the fact that not only is he ketotic, his bicarb is up, but he's also got a low sugar. So I think that seems to be the lab test that matters, but you don't have to do a battery. And the other thing is we're not particularly interested in what the sodium is. I know that there's all these papers that talk about high sodium dehydration and low sodium dehydration. They're all going to be treated the same way. So if they're all going to be treated the same way, so if the sodium is 150, we're going to fix it. And if sodium's 130, we're going to fix it kind of thing, because we're not going to really substantially change fluids based on on that. So when it looks, the key numbers were sugars and bicarbs. And the bicarb is going to be fixed by your giving this kid calories. So that's not a big thing. I think that the thing that is a recurring number here is surprisingly low sugars, unpredictable who they are. The advantages of IV versus oral dehydration are addressed in the next papers. Number 10, American Academy of Pediatrics, World Health Organization, and the CDC, mild to moderate, they get oral rehydration. And then the reason they ought to do it is because you don't have to stick an IV, plus the parents get to see that this works in the majority of the cases. We'll talk about some of the specifics in a minute. So number 10 here is randomized trial, 73 kids with moderate dehydration comparing oral and IV in these kids. Some of them were only 8 weeks old. And the rates of successful rehydration by 4 hours, and that number is going to come up over and over. The number is 4 hours. Refill the tank in terms of how much do you think that they need in 4 hours. 6 is kind of the outer limit. This idea of rehydrating over 12 hours and 24 hours, it's fill up the tank. 4 hours is the time that you can remember. 6 is the outer limit of that. Parental preference was the same between IV and oral. I would think that the parental preference would be better for oral. Admission rates, look at this. The oral group got admission rate of 31%, IV group 49%. Why are we admitting them? We're going to fill up the tank in 4 hours, then we're going to refeed them, then we're going to send them home, kind of thing. So why would we be admitting such a huge number of kids that had dehydration? A quarter of the children receiving IV therapy required 3 or more attempts to start the IV. And the parents are there now, and they're all getting, and you're losing credibility. And the nurse, now we're calling down to the NICU, can you have a new nurse come up here and do this? And everybody's kind of getting a little uptight now because this is the 4th time you've stuck this little bugger. And we see that all the time. 34 patients, randomized, moderate dehydration. We're talking about IV versus oral. Look at this, admission percentage for both groups of patients were more reasonable than the prior study. Only 11% got admitted for oral rehydration. A quarter of them got readmitted if they had IV hydration. So it doesn't make a lot of sense. Again, a high admission rate. Unlike the prior study, the parents substantially preferred oral rehydration. First study, it was about the same. Second study, they preferred oral. Makes sense. And eating times are shorter with the oral rehydration. So parents like it, gets the job done. We'll see how many people fail. The number there is always kind of an issue. We'll get down to that in a second. 12 is 16 randomized trials looking at this matter of IV versus oral. Weight gain was comparable, length of stay was shorter by 20 hours, and the composite of these 16, the kids got out of there 20 hours sooner. What was the failure rate? 4%. Very low, 4%. Now that may not be your experience. I think that number is low. But now that we have our Dancitron being used right and left, maybe that number is a reasonable number. Maybe it's 5%, maybe it's 10%, but the vast majority of these kids are going to pass oral rehydration therapy. Satisfaction scores, high satisfaction scores were twice as common by the parents in those kids who got oral rehydration. A lot of these studies were done in third world countries where oral rehydration is the rule and is more appropriately used. But in the bottom it says, U.S. favored treatment of dehydration with IV therapy is not in keeping with the recommendations of many organizations and appears to fly in the face of the evidence. 13 is a new study. And it said, we're going to educate the parents about oral and IV. And then we're going to ask them what they would prefer. And in this study where they educated them, which means you can spin it any way you like, the parents actually preferred IV therapy. Why did they prefer IV therapy? Because they knew it would get the job done. The kid would get the fluid that they needed within the 4 hours, and that was great. So 62% preferred IV therapy, especially if a topical medication could be used so that the 4 times they're stuck will not be as painful. But more than half who preferred IV therapy stated they would choose oral therapy if there was a medication available to decrease their likelihood of vomiting, which now there is. Everybody's getting a Dancitron in the States when they're going to get their rehydration therapy, so there's not a big argument about it. It doesn't hurt you, it doesn't put you to sleep. No black box around it like they have with Phenergan now, which is going to kill you. It wasn't killing you in India for the last 40 years, but now it is killing you, kind of thing. So basically, it was when we told the parents what the options were, they really would prefer the oral, as long as we didn't, the issue with the oral was it might not work. The issue with the IV was it will work. 5 sticks, 4 sticks, 3 sticks versus oral might vomit. We can take care of both of those problems. And then anybody use NG tube? NG tube for rehydrating kids? You know, it sounds like a reasonable thing. Number 14 suggests NG tube rehydration, Pedialyte, multiple advantages over IV, now how many attempts did they had to put the NG tube? 4% of the kids required multiple attempts. How many percent of the kids required multiple IV sticks? 60% of the kids required multiple IV sticks. Both groups got a similar amount of fluid. Multiple outcome measures were similar when you put NG tube down. That isn't done, I guess. Nobody raised their hand, or nobody wanted to admit that they do that. But you know, it makes some sense, actually. Then the last thing here is gradual versus immediate. Gradual is half strength formula, then we're going to full strength formula, 3/4 strength formula. We're going to do a period of stomach, we're going to rest the bowel. You've seen people go in there and say, okay, we're not going to give Johnny anything for the next 6 hours and rest his bowel. And then we're going to start refeeding them. All the literature on this says, no. Fill up the tank in 4 hours in terms of their deficit. Full refeeding at that time. These kids are calorie deprived, particularly if they have diarrhea. It's been shown that they are calorie deprived. So the idea is full age-appropriate diet. We're not talking about half-strength anything. We're talking about pizza. Whatever their age-appropriate diet is begins in 4 hours. Now, obviously, if the situation is diarrhea, it's a no-brainer. You can feed them anything because the problem is at the other end. If it's a vomiting problem, then that might be something where you want to be a little bit more gingerly. You're still going to give them something, hopefully, for the keep things down. But diarrhea, it's clearly a no-brainer. There's a number of these papers that talk about the rate of refeeding, and if you were to look at the one that I think is the strongest, the consensus is full age-appropriate diet upon completion of rehydration. Rehydration is done in 4 to 6 hours. And that is summarized in papers number 16. I like that one for that as well. 18 is a survey, a really old survey of physicians' beliefs regarding what you ought to do and comparing it with recommendations. Even these recommendations are out of sync now. Like the brat diet, you know, bananas, rice, apples, and toast. Sounds pretty horrible, to tell you the truth. Even if you weren't sick. So the idea is basically, there's nothing special about that diet, and there's nothing special about giving this food versus that food is basically going to affect the outcome of these cases at all. And the last thing I wanted to get to, I wanted to skip through some of these other papers because they all say the same thing. They prefer rapid rehydration, full calorie load thereafter. The last thing is about soy formula. And most of the people, like Merck Academy Pediatric says, nah, give milk formula, mother's milk, or cow's milk-based formula, and that should be fine. But there are 2 papers here that look at the development of lactose intolerance in the setting of these illnesses, which can cause these, the bowel, small bowel in particular, to become lactose intolerant just temporarily as a result of this process. And you don't know who those kids are. And if they are lactose intolerant, they become more gas, more diarrhea, more problems. And despite the fact that most of these papers say give whole milk or milk-based formulas, there are 2 papers in here that said we found that the incidence of lactose intolerance, well, paper number 24 was 30%. Paper number 23, it was 42%. 42%, that's not a small number. So why would it be a big deal to say for a couple of days, let's try some soy-based formula, Mom, in this kid who's had some reasonable amount of diarrhea for a period of time. And it's primarily related to diarrhea, more so than vomiting. You know, there's the phrase gastroenteritis. Gastro is the vomiting part. You gotta have vomiting for gastro. And you have to have diarrhea for enteritis. So you're gonna put that diagnosis down. Kids are vomiting and having diarrhea. The last one here, 24 is the recommendation of AAP. I don't think there's any reason, unless you can tell me one, why not to recommend in kids who have substantial diarrhea a few transitional days of soy-based formula, knowing that this is not a theoretical kind of thing. 2 papers, 30 to 42% basically is the number. And lastly, a little warning about apple juice. Apple juice is sugar and water. And some of these kids who have diarrhea, their ability to absorb sugar is compromised to a certain degree. So now you have the opportunity for an osmotic diarrhea. Number 25 is just a report of 5 cases of chronic diarrhea ultimately attributed to excessive apple juice consumption in the setting of carbohydrate malabsorption. They said that this can also occur in the acute setting as well. So I think that that's it. I think that there's really not much more to this topic. Any pediatricians in the room? Did you? Yeah, this is evidence proof. It's always worked before. Why would you change what you're doing?
What's the dose of ondansetron for babies?
Well, you know, it's 2 or 4, but it doesn't matter because, you know, there's no side effects from this stuff, except we have another chapter which talks about more specifically ondansetron. It has been associated with an increase in diarrhea thereafter, which is really unusual because most of these kids only get 1 or 2 doses, and then the next day they have a little bit more diarrhea. How does that work? Have you seen that? That is consistently reported. Some slight increase in diarrhea with ondansetron. I don't think it matters though, because it's such a great drug. Although the literature on this says, yeah, it's better than what we had before, but it's certainly no miracle. No miracle compared to things when they've been compared head to head with Phenergan kind of, and yeah, it's a little bit better. It's a little bit better.